My sincere thanks to the organizers. We have 3 papers in this session. And first speaker will be Dr. Vijay Viswanathan, who will be talking to us on glucose, weight, and vascular protection. What should be the priority? We have seen the priority with Anjana, and now we'll have to see with Viswanathan, Vijay Viswanathan. Over to Vijay.
But if there are any questions, you can ask me after my talk, because I have to go to another hall after this talk. So the question is whether it's glucose, weight, or vascular. And the answer I can give you in 1 minute, 30 seconds. It is all the 3. You have to maintain your HbA1c, you have to maintain your weight, you have to look after your blood vessel. So the answer is, what should be the priority? All the 3 are priorities. So with that, I'll justify. This is my father who finished 100 years of his life and left us. And he joined Stanley Medical College in 1940. So this talk is actually dedicated to him. Now, type 2 diabetes is usually complicated by 3 factors. We are all concerned about this. The pointer is not working, no? But we are least concerned about cardiovascular and renal. And I'm going to talk to you in the next 10 minutes or 9 minutes on metabolic, renal, and cardiovascular benefits which accompany type 2 diabetes. Diabetes is a vascular disease. This is John Cockcroft's famous slide. It affects every blood vessel you can think of: cardiovascular disease, stroke, diabetic nephropathy, retinopathy, neuropathy. So it occurs anywhere in the body, and diabetes can affect any part of the body. This was one of the earliest studies from India, where we showed that diabetes is a very, very expensive problem in India. We estimated $31.9 billion. In 2010, that's about 14 years ago. But 14 years later, the cost is tremendous. Who's going to bear the cost? It's a patient. So you have to treat, de-escalate, as Rajiv Kovil said, and as Anjana said, it's a real problem. But we have to de-escalate. So it's a very, very expensive disorder if you don't. This is a slide from the same study by Dr. Satyavani, who is sitting in the same auditorium. We looked at it, the number of complications and the cost. You can see that we looked at the patient and the primary caregiver. If it's a husband, it's a wife. If it's a wife, the husband. And we found that as the number of complications increased, and this was published in DRCP way back in 2010, 14 years ago. So you see that the cost increases as the number of complications increase. So this is why we have to follow, though it's little old data. This was the first time in the world that the ADA EASD came up with this management strategy. And what I'm going to talk in the next 8 minutes is going to be on this ADA and EASD guidelines. Now remember, type 2 diabetes doesn't start here. It starts at least a decade, 10 years before you actually detect diabetes. So the complications of diabetes start, heart failure and so on, start at least 10 years before. Now, pre-diabetes on tuberculosis. Now, this is a study which we published recently, and we showed that pre-diabetes, if you have, more deaths are there from tuberculosis. If you have pre-diabetes, not diabetes. So if you have pre-diabetes, you have more death from tuberculosis. Aruchelvi, I think she's also in the auditorium. She looked at the heart failure in people with diabetes, and we found that as the prevalence of diabetes increased, as the duration of diabetes increased, the prevalence of heart failure also increased. This was published in the Diabetes and Metabolic Syndrome Clinical Research and Reviews by Anup Mishra, which is now the #1 journal in the world, or in India at least. So therefore, the main emphasis is on cardioprotection and glycemic control and weight management. You should not forget that these three elements are very important in trying to, when you manage diabetes. So managing diabetes is not just HbA1c, mind you. You have to look at the heart, you have to look at the kidney, you look at the weight also. The patient shouldn't put on weight. So with this in mind, you have an agent now. I'm going to talk in the next 6 minutes about dapagliflozin. I've taken one gliflozin and say why it's to be used more extensively. And mind you, this talk, I have no conflict of interest. It's not sponsored by any company. So I'm talking purely from science point of view. So this is a drug which has a benefit on the pump, the pipe, and the filter. The pump is the heart, the filter is the kidney, and the pipe is the blood vessel. It has got benefits on the heart, kidney, and on the pipe. Now, renal and cardiovascular disease are interconnected. If you have kidney disease, people think they die of creatinine, high creatinine. No, they will not die of creatinine. They will die of heart failure. They will die of heart disease. So people are more worried about the creatinine going up from 4 to 6. They don't realize that they will die of kidney disease, not of kidney disease, but of heart disease. So there is a connection between the kidney and the heart. And this is why you should use agents which can protect your kidney and the heart at the same time. So the ADA in 2024, this year, has come up with management of diabetes. And fortunately in India, the dapagliflozin is cheaper and it's gone out of patent and you can use it. But yesterday there was a video in the WhatsApp by Dr. Shashank Joshi that all the drugs are fake. So we don't know what to use. So if you use fake drugs, you don't know where you will end. And many of the anti-diabetic drugs are fake. So you can use Foxiga in that respect. I am again not supporting AstraZeneca, but I'm just supporting the molecule. So there was a video just last night I saw. So you should use, if there is evidence of heart failure, there is evidence of kidney disease, you should certainly use the SGLT2 inhibitors after metformin. Now, cardioprotective and renoprotective effect of SGLT2 inhibitors, I need not talk about it. It's a known fact that it protects the heart and the kidney. Now, how does it reduce weight? You can read the slides. If you want a copy of the slides, you can ask Dr. Shanmugam for the slides. It is not due to calorie loss alone, but there are different mechanisms which have been explained how SGLT2 reduces weight. Now, in proportion to the weight, so don't be surprised if you use dapagliflozin in low BMI people and they don't lose weight. There's been studies have shown that it offers weight reduction in proportion to the BMI. So this is probably a drug which can be used. At present, we have data. Innumerable research has shown that it offers multiple benefits. And you get a good reduction in blood sugar. There is a durability. It's not that after 4 years it will lose its potency. It will stay because it's got an insulin-independent action. Now I'll end up in the last 2 minutes of my talk about linagliptin. Why you should use linagliptin versus sitagliptin. And there are no studies simply showing sitagliptin and vildagliptin are good for the heart. They're not done studies. Maybe they're good. But there are studies using linagliptin in kidney function. So linagliptin has got multiple benefits, and you should use linagliptin. In combination with metformin and DPP4, still better. Again, I tell you, it's not a talk for a company. It is only a molecule. So I'm not talking for any company. I've not been asked to talk for any company. The slides were prepared by me, and you don't see any particular company's name written or product written. So linagliptin has got a favorable effect on the endothelial dysfunction. We have shown that endothelial dysfunction is there in diabetes, in diabetic nephropathy. We have shown in our studies flow-mediated dilatation, and we have published it several years ago, that there is endothelial dysfunction in type 2 diabetes, especially when kidney disease is there. So linagliptin is useful to improve endothelial dysfunction. Now, renal outcome of SGLT2 inhibitors, the slides are a little jumbled. So I'll finish in another 1 minute. So don't worry. So empagliflozin, these are two people who showed the EMPA-REG study and the Carmelina study. We have data to show that these agents are better than other agents. Therefore, when choosing drugs, anti-hyperglycemic drugs for patients with type 2 diabetes and CKD, you use metformin. You use SGLT2 inhibitors if there's evidence of CKD. And CKD, don't say it's 60 and up below. It's 90 and below, EGFR. Gone are the days when you should calculate serum creatinine. It's done only in India and Pakistan. So you should estimate the EGFR. It's very easy. We have published 2 studies in the Indian Journal of Nephrology that CKD-EP formula is good for estimating the EGFR. So EGFR should be used, and use SGLT2 inhibitor if it is less than 90. Therefore, to summarize, ladies and gentlemen, chairperson, my teacher, Dr. Sundaram sir and Dr. Rajendran sir, if you have type 2 diabetes and heart failure and chronic kidney disease, don't hesitate to use SGLT2 inhibitor. Dapagliflozin, empagliflozin, you are free to choose. Canagliflozin has positive effect on the metabolic parameters. Don't worry about amputation. If you have a foot ulcer, if you have peripheral arterial disease, treat it. Treat the peripheral arterial disease and use the SGLT2 inhibitor. Nothing prevents you. No study has shown after revascularization it's harmful. No study has shown. What Basab, you are very active in CME India. So has any study shown that SGLT2 inhibitors are bad after revascularization? No, I have not finished. You should continue. DAPA reduces MACE and progression of chronic kidney disease. And we have Sundar Mudaliar, who is coming to Delhi RSDI, and we have many speakers on SGLT2 inhibitors coming to Delhi RSDI. I welcome all of you to Delhi. I don't have a slide on that. To welcome all of you. And yesterday, Shashank Joshi has written that the Franco is ready to come for the meeting also. So maybe the Franco also will join the Delhi RSDA. This is only a US FDA drug. I don't know whether EMPA is still not approved by the US FDA. SGLT2 inhibitor for the treatment of heart failure with reduced ejection fraction. It also reduces the risk of cardiovascular death and hospitalization. So right now, do we have data to show that it prevents CKD, so above 90 and no heart failure? I don't think there's data. Data is yet to come. What was up? Is there data to show? But heart failure and CKD, definitely you should use dapagliflozin or EMPA or canagliflozin. So thank you for your attention, and I see you all at Delhi RSDA main national conference.
Hello.
Thank you very much.
Hello. Thank you, Vijay. First of all, for accepting that diabetes is a vascular disease. blood vessel. I used to say it is a blood vessel disease. Where is the sugar present? It is in the blood vessel. So the sugar, the container and the contents both are affected. That is the teaching we had in those days from Professor Samjit Moses and Vishwanathan. Thanks for emphasizing that. So diabetes, don't say it is a blood sugar disease. Say it is a blood vessel sugar disease. That's the first point. Second, you've taken the subject of controlling whether to control blood sugar, obesity, or the overweight, and then save the blood vessels. All the three are important because the diseases are imposed upon us by government. I want to say this because 10 to 15 years, if you look back, nothing was there and all the food substances were allowed into India. So for the last 10 years or 15 years, they made our children to become obese and all our physical activities are made to go less by Zomato, tomato, whatever it is, food supplies. And then introduction of all the gadgets, as madam said, all our activities have gone. So stressing upon the activity and the diet still plays a major role. And then protecting the organs from day one of detection of the disease or even in pre-diabetic state. Now more education is required. So since he has got a meeting in another hall.
No, Dr. SSL wants to ask a question.
Yeah?
I hope it's a simple question.
I have only one question. Dr. Vijay, as you said, SGLT2 inhibitor is one of the wonderful molecules which has been introduced. And even though there is no diabetes, many of the cardiologists use for cardiac failure and renal protection. Now, I just want to know what is the lowest EGFR till which is this DAF or any SGLT2 inhibitor can be used?
The latest criteria says you can use up to 15.
Till?
15 EGFR.
15. Yeah.
During dialysis also. So I was talking to Peter Rossing in Denmark, from Steno Diabetic Center. He's the chief physician now. He said you can use up to 10, even on dialysis. I chaired his talk in IDF and he said you can use it because it's giving oxygen. He connected the kidney to an oxygen cylinder and he said it is like giving oxygen in dialysis. So even during dialysis you can give the SGLT2 inhibitor. 15, sir, to be very specific to your question. Rajendran, very simple question.
Vijay, I'm not, just a comment, it's not a question to you, and really a good talk, and really appreciate that you talked only about the molecules, and definitely...
I'm sorry.
Yeah, you said very importantly that nobody dies of just increase in creatinine. Whenever the creatinine goes up, the cardiovascular mortality and morbidity increases. Again, we look at the diabetic foot also. When you look at the diabetic foot, I see that it's a sign of endothelial dysfunction happening everywhere. So, as a holistically, we have to treat, that's what you said. Very nice, Vijay.
Thank you, Dr. Vijay, for having told certain basic things. Not only the diabetes and also the complication, they start 10 to 12 years before the onset of the diabetes. And another practical point, as Dr. Balamuran also enlightened, because people have been giving much importance to the management of a CKD if they are dealing with, but finally, and most of the patients, they die of cardiac problems. And number 3, and you have told about that the usage of the SGLT2 receptor blockers, DAPA, CANO, EMPA and other things, still things are in the mind, whether can be used because of the certain subtle complications like urinary tract infections and also that the euglycemic ketosis, which has been seen lesser in the practice, and also you are nicely advised to go ahead with. And as you know, that's the usage of this linagliptins, and of course with metformins, we do not have, as you said, that the studies, why should it has been? In fact, for example, in Bangladesh, most of the practitioners, they prescribe this linagliptins rather than the other gliptins. So nice presentations. Once again, thank you on behalf of this track. Thank you, Vijay. Next topic, that is the use of premix insulin in the Indian context by one of my colleague, senior colleague, Professor Dr. S. Venkatraman. He has got more than 2 decades of experience in the teaching as well as the practicing, 40 years. And he is retired as a professor of diabetology at Madurai Medical College. And presently, he is a senior consultant diabetologist at Apollo Hospitals. And he is going to talk about the most practical aspect of that, the insulins, which is still that the as how this insulin usage is myth. There are a lot of myths occurring in that the general public. So many doubts are also prevailing among that the practicing diabetologists. I hope Dr. Venkatraman will clear all these things. Dr. Venki, please.
So good morning. Thanks, Dr. Rajendran and respected chairpersons. Thank you so much. And hats off to Shanmugam and team for the brilliant arrangements. Of course, we are part of the RSSDA, and then meticulously the details have been worked out, and then you see the evidence in front of you. So unlike Vijay's presentation, mine is talk. I have been contracted by CIPLA to make this presentation, and it is going to be on a molecule which I feel deserves a space for patronization, taking into context the efficacy, the safety, the cost effectiveness, and the rich experience that we have with this mode of therapy, and more appropriate in the Indian context. So I'll just cover it up in the next 14 minutes about the unique features of the type 2 in the Indian population. I think what I'm going to do today is probably something very, very fundamental, which has been discussed in so many fora, which all of us are practicing in our day-to-day practice of diabetology. We are utilizing this concept and then patronizing this molecule. Just re-emphasize and reiterate the points that is already known to us, and maybe wind it up with a couple of case discussions. Again, very, very simple discussion. All of us are very much aware of that the type 2 Indian diabetic patient has got a different phenotype. So the insulin resistance component is much more known. The central adiposity for the given BMI is much more. And what has been documented is across India, I think Anjana right now pointed out the importance of the carb content in the Indian diet, whether it is rural or urban, whether it is north, east, south, or west. I think we have high carbohydrate content, as has been captured by this elegant data. What I would like to add in this context is, even for the given carbohydrate load, the glycemic excursions in the Asian Indian population is much more for the same glucose load. I think this has been documented. So this gives a lot of, what shall we say, credence to the speculation that probably the secretory defect is as important, if not much more as important as the insulin resistance. And we as a genetic type have been disadvantaged with a good amount of secretory defect, contributing to the postprandial excursions besides the dietary habits, besides the response of the individual to a given carbohydrate load. So that's the second point. The third point is, as we have understood the pathophysiology of diabetes mellitus, I'm not going to go into the details, as we travel from the initial pre-diabetic stage to diabetic stage to situation wherein patient is on board with 2 or 3 molecules, the conventional teaching is the liver produces so much of unwanted glucose, silence the liver by a good basal insulin, NPH insulin, or the basal analogs, so that once you achieve this, the postprandial can be controlled with your reinforced lifestyle modification and the OHS on board, and with the correction of glucotoxicity, certainly. While this is probably universally true in the context of the Caucasian population, in the Indian context, as depicted in this particular slide, You see here, quite often, the left is the studies on the Indian population, on the right is the Caucasian population. The irrespective of HbA1c. In the Caucasian population, we used to say the Monier's data, all of us are very much aware of. As the HbA1c is very high, the contribution by the fasting is very high. Target the fasting first, fix the fasting first. Whereas in the Indian population, irrespective of HbA1c, and more so at higher HbA1c, the contribution by the postprandial is very high. The message is, target the prandial as much as the fasting, either at the insulin initiation, or soon after initiation, so that a combined targeting the fasting and the prandial, which is most practical, which is most cost effective, which is evidence based, probably requires a good amount of patronization in the Indian context. Of course, a little bit of theory about the postprandial hyperglycemia. All of us know that diabetes have to be controlled. The importance of postprandial control, I feel, is there when you look at the sequence of events in the temporal relationship. So you have a non-diabetic, then you have a pre-diabetic. In the pre-diabetic stage itself, you have an increased prevalence of macrovascular disease. Why? Even that excess of glucose which could be present, what we seemingly interpret as transiently, the generation of free oxygen radicals, the inflammatory response cascaded, plus other activities. In other words, it is a continuous journey of the initiation and perpetuation of atherosclerotic cardiovascular disease linked definitely to the metabolic factor, and even excursions which we probably tend to ignore at times when the fasting blood sugar is normal might be associated with impact on the postprandial, the events of the postprandial period can impact all these six mechanisms. The end result is event. Now, coming from the point of view of the treatment, so we know that the postprandial blood sugar is very high. The postprandial blood sugar contributes to the HbA1c. Why the postprandial is very important, and the clinical significance we have seen. And also from the point of therapeutics, probably it will be wiser enough not to ignore the fasting, but to target the PP as well to achieve the target HbA1c, number one. And also, if you look at the other endpoints, a crude endpoint of mortality, then certainly there are studies which have compelling evidences to suggest that the mortality is associated with either postprandial or post-glucose blood sugar level. And once you target the postprandial blood sugar level, possibly, certainly we have seen in the day-to-day practice, you start with a basal insulin, soon or even at initiation you had a prandial component, the journey with which you undertake to achieve the glycemic target probably is much more smoother if you target both rather than the fasting alone in a good chunk of our diabetic patients. So the insulin in the Indian context, are we starting at the right time? The answer is no. All of us are aware of it. Probably we need to improve a lot because the molecules are available, the science is there. It's up to us to tighten up our socks or whatever you call it so that the better care is delivered, and then allowing the HbA1c to creep. It's not the patient, physician-related factors alone. The patient factors are so much important whenever you entertain the introduction of an injectable into the therapeutics of diabetes mellitus, but HbA1c of over 9 to introduction of insulin, certainly from our side probably we need to do much, much more. Action profiles of insulin, I'm sure for this August audience, it is not just for the completion's sake, because subsequently I'm going to talk maybe in the next 5 to 6 minutes on the Lispro mix 25 as well as 50, just to give about the action profile, how the rapid acting analogs have made a sea change in my opinion. For the simple reason, yes, they are slightly expensive than the human insulin, but still the hypoglycemic advantage, even though not very much documented in the literature, you and I have seen it obtained number of times repeatedly in the day-to-day practice. And when you have a combination of a Lispro or an Aspart with a protominated form, in the form of a mix, it becomes so easy for the clinician to target the fasting and the PP for the reasons that I've already alluded to, number one. And number two, the titration calls for a good amount of control with, of course, backed up by minimal amount of monitoring so that the glycemic target is easily achieved, the time profile, etc., etc. Again, I'm skipping through this slide. Of course, we do have other players in the market. You have the basal bolus, you have the co-formulations, etc., etc. As we discuss about the therapeutics of diabetes mellitus, be insulin or OHA, I don't think we are talking about a single prescription. all insulins do have a space. It is up to us, the clinicians, to identify the patient in front of you who will be the right candidate for the molecule that you are entertaining for him or patronizing for him. So the guidelines, especially the RSSDA guidelines and the NICE, I think we have been cognizant of the fact that a good chunk of the population are huge in carbohydrate content in the diet. Postprandial is very high. Even at the time when the glycemic escape is there, it's not sufficient if you target the fasting alone. Yes, basal insulin is there, recommended by the various guidelines, but guidelines are not found wanting with respect to emphasizing the need for addressing the prandial, either with a co-formulation or with a premix. The starting dose of the basal insulin, all of us are very much aware of. This is just to say the NICE guideline, how you start, how there is a space for premixed insulin. In this context, I would like to say, when we had the COVID, I think there was a specific guideline by the NICE, if I remember right, because when you give a daytime steroids, the post-lunch blood sugar level, the mid-afternoon blood sugar, is better controlled with an NPH insulin rather than even probably with a basal insulin analog. Maybe just correct me if I am wrong. That's my memory with respect to the. This is our guideline. Yes, the premixed insulin have a space, an identifiable space, a discernible space, be it biphasic insulin, maybe with some advantages and adjustment facility, you have the premixed analogs, about which I'll spend the next 5 minutes of my presentation. Whenever you talk about the first injectable space, a basal insulin or even before that a GLP receptor agonist, yes, it caters to a subset of patients, certainly backed up by good science and evidences, but we are talking about the positioning of a molecule in the context of the whole Indian population, wherein you have to combine efficacy, safety with cost effectiveness or affordability. So the premixed insulin, when do you choose a premix rather than a basal insulin? If the difference between the fasting and the PP is more, all of us are very much aware of, arbitrarily a cutoff of 3 millimoles or 55 milligram is given. I think in the examples that I gave also, the difference between the fasting and the PP is so high so that the clinician doesn't have much of a doubt with respect to addressing the prandial component at the time of insulin initiation itself. So other aspects in the phenotype, the duration of diabetes mellitus, presence or absence of symptoms, of course, compelling indications, comorbid conditions, I'm not talking much about. So these could be other markers in your clinical decision making about considering a prandial component in addition to focusing the basal as well in a given patient when there is a need for introduction of insulin on top of OHAs. Yes, again, re-emphasizing the point, where do you consider a bolus? Now, before I wind up, I'll just summarize few data, not go into the individual data. So whenever you have a patient who requires insulin, then the ideal, I think we did have a small discussion about basal bolus also. That is, this could be certainly probably a situation which is demanded in most of the inpatient situations, the common or an outpatient variety. Yes, if there is a compelling need for glycemic reasons to have a basal bolus, certainly you make an effort, quite often needs to be continued. But what are the evidences? If you look at the outpatient scenario, these are the 13 RCTs. The quality of control as captured by the HbA1c is similar between a premixed as well as the basal bolus, at least as evidenced by these 13 RCTs. And of course, whenever you say, when you have a basal bolus, you have that amount of titration facility, but you have to balance it with the 4 pricks and then the compliance of the patient and then his willingness to adhere to such a complex schedule. It is safe. But if you look at the RCTs, the risk of hypoglycemia has not been significantly high as well in the So for a good glycemic efficacy which is comparable to the basal bolus, if the hypoglycemic risk is also comparable, maybe numerically it is more, but not statistically significant, and also the weight gain, I think it is worth the patronization because you are addressing signs, you are achieving the glycemic target, and of course coupled with good amount of monitoring, so you are able to position some of these combinations, especially in the context of today's discussion. There are two molecules. One has got a prandial component of 25%, the other is a 50%, and the other attributes we are very much aware of. A case, a female, I think I'll finish in another 2.5 minutes, 3 minutes. A female, 12 years, yes, look at it, on board with 3 OHAs in maximal or submaximal dose, HbA1c. I think this is a hypothetical case. Purposely, we have given the picture in such a way, there is no confusion to the clinicians. Fasting is 146, PP is 255. The difference is so huge. EGFR is, the patient has got CKD A2, G3, yeah, I mean G2, sorry, and the lipids have to be addressed much more aggressively. So what do you do in this patient? Look at the evidences. When you have this patient, obviously in this patient, I don't think any of us in this audience will consider basal insulin alone. Maybe for higher blood sugar level of fasting, we'll have entertained the possibility of introducing a basal. When you compare the basal insulin with the Lispro mix as depicted here on top of metformin, look at the HbA1c, fine, it is better. And also look at the people who have been able to achieve the glycemic target, the total, the fasting, the PP, the HbA1c, etc., and also the meal-related blood sugar levels as low as 180 or 140 you can achieve. And overall hyperglycemia, yes, certainly it will be there. It can be anticipated, it can be addressed, but you are able to achieve a glycemic target aggressively in a given patient. So this patient was introduced with a small dose, maybe you and I would have introduced with maybe around 12 units, and then up-titrate the dose so that at the end of 3 months, you are able to have HbA1c reduction of from 9.3 to 7.5 with split doses of Lispro Mix 25. A second case before I finish is, this patient is already on a Lispro Mix 25. I would like you to focus on this particular point because very interesting is the point of view of discussion. Now the HbA1c is 9.2, and then at the end of the day, at the back of your mind, you're convinced that this patient requires probably an intensification of insulin, maybe a basal bolus, maybe something else. Now, look at the pattern. The meal-related excursions are much more, 113, and of course for the lunch it is only 30, and after dinner it is 72. On top of your you are giving a mix, Lispro mix with 25% of the component of the prandial component. Now, what you do is, if you consider 50-50 without escalating the dose, just switch over, then you have data to say that they compare, they perform as effectively as basal bolus. When you talk about Humalog, say 50, Lispro mix twice a day, sorry for using the name, of course it's a company-sponsored program, and you look at the target HbA1c. You can achieve a target of as low as 6.5, and look at the hypoglycemia, at least as captured by this particular data, which involves about 400 patients roughly. Look at the total and the nocturnal hypoglycemia. So, when you have a patient who is already on a Lispro Mix 25, the postprandial excursions are even much more, unable to be captured by the 25% component of the prandial in the Lispro Mix. You have yet another option of Lispro Mix 50, which was done in this case without escalating the dose. On the other hand, the dose was slightly reduced. When you do it, you are able to achieve with marginal adjustments. So ladies and gentlemen, this was a simple presentation just to impress upon you the patternization of a time-tested combination which you and I have used in our clinical practice. And it is more relevant in the Indian context because the postprandial is high. And postprandial needs to be adjusted for its own advantages and also for achieving the glycemic target. So with this, I'd like to end my presentation. And thank you all for the patient listening, and thanks Apla for the opportunity.
Thank you, Dr. Venkatraman, for having elaborated about that the usage of this pre-mixed insulin and insulin analogs over that the glargines, and also he clarified the doubts in what clinical situations these insulins should be addressed, and also he has given the importance of controlling not only fasting as well as the postprandial and the insulins of choice. Hope, I think, to a certain extent, Dr. Venkatraman has clarified. If you have got anything more, you can feel free to ask the speaker.
So pregnancy, I think I'll make it very quick. I make a distinction. In a pre-gestational diabetic, especially type 2, of course type 1 it is needless to say, I prefer basal bolus. So in the case of gestational diabetes mellitus, I also control a lot of patients with the prandial insulin and metformin if it is convenient to my obstetrician and the other people who are involved in the... Otherwise, pre-mixed is an option in the gestational diabetes mellitus. But pre-gestational diabetic going through pregnancy, I feel basal bolus will be the best option, and also a type 1 diabetic.
Sir, I have a small doubt on this. When you use a condition where you need to use premixed insulin, can we use basal insulin one dose with the SGLT inhibitors and the DPP inhibitors on the other hand? So you to address both will address the postprandial. One dose will suffice for the postprandial. Is it okay, sir? Is it need to add?
In fact, this question was asked by one of my teachers. So when you combine a premixed insulin, you are depending upon the NPH component for the basal support. When you're using a basal insulin, it is a 24-hour action. So there could be a spillover effect, and then even though, of course, there is no recommendation, I think logically, to combine an NPH insulin and a basal insulin in the same patient, I wouldn't be too comfortable.
Check. Sir, is there any possibility of using a combination of the co-formulation of GLP-1 receptor agonist or glargine? Because basically these also addresses the fasting as well as postprandial hyperglycemia. Will it be of any place in when you have a elevated fasting as well as postprandial, especially the data we have presented, the obesity is increasing, the BMI is increasing. We can address the weight as well as when the weight is reduces, insulin requirement also comes down. Is there any scope when you try to look at the human mix, all these things?
Yeah. I totally agree with Dr. Malburgan. So now I think the therapeutics have, we have a basket of molecules. This co-formulation of glargine with Lixi has become so handy because not only it is going to address obesity, treatment-associated weight gain is always there. See, whenever you introduce insulin, be it a basal insulin or a co-formulation or a premix, always you should anticipate a weight gain. If this treatment-associated weight gain is going to be partly taken care of, even though Lixi may not be very aggressive in promoting weight loss, certainly the treatment-associated weight gain had been at another prandial component in the form of insulin, certainly will be neutralized by this wonderful combination. We have started using it. I think the initial results, I'm sure, like you, we are quite happy with the response.
If there are no questions, I think it's a time to wind up the sessions.
Thank you.
So I have to thank the speakers for having nicely highlighted all these the factors. Thank you.
Postprandial blood sugar as predictor of complications. We usually check 2 hour blood sugar for postprandial. Now 1 hour blood sugar and what are its effects? Dr. Great Vijay Kumar is going to present. And Vijay, we had GTT clubs. I think Venkatraman, Pannir and other, way back in 1980. Then itself we have observed something at 1 hour. Whether it correlates with hours, we will see, and then I will talk.
This is a slightly different topic actually. Should 1 hour post-challenge blood sugar after the GTT can be a biomarker for glycemic mortality and complications? That is number one. And we know that postprandial hyperglycemia is the independent risk factor for many diseases, including cardiovascular disease and microvascular complications. And though the data that I'm going to present is going to be with the 1 hour post-challenge blood glucose, it's different. Now, conventionally, we used to see that a long time ago, GTT means we used to do fasting, half an hour, 1 hour, 1.5 hours, and 2 hours. That's it. Then we have reduced it to 3 GTT, that is fasting 1 hour and 2 hour. And whereas later on the WHO and IDF has created that, just do a blood sugar after glucose load, just do a 2 hour blood glucose, and if it is between 140 to 199, it is IGT, and if it is more than 200 and more, it is diabetes. That's what is being there. But meanwhile, we have not taken into consideration the 1 hour value. And then recently there has been a lot of talk about 1 hour value being a very good predictor for mortality and morbidity in complications as well. So this is going to be taken. All of us know that hyperglycemia causes micro and macrovascular complications. And if you look into that, the exposure of the tissues, especially the endothelium, to the physiological blood glucose values, to the basal hyperglycemia and the postprandial spikes as well. It's all together. You could see that they have been exposed, and then that's the reason you get microvascular complications. I think this is one more study that Dr. Venkatraman is also talking about. The fasting PP and HbA1c. In general, as HbA1c is high, the contribution from the postprandial is, fasting is higher, but in Indian population it's a different data. You can see that in HbA1c 9 itself, you can see that postprandial component of contributing to HbA1c is very, very high. And then as it comes to 8 and less, 70% of it is contributed to postprandial blood glucose. The reason why we need to look into is that when such a thing is there, that when postprandial blood glucose is there, then why this 1 hour? Now, if you look into Indian dietary pattern, which Dr. Venkatraman is also explaining to you a lot, and then the study done by Dr. Mohan et al., and also I think Dr. Sundaram was also, Professor Sundaram was also speaking about, because the blood glucose at 1 hour is going to be the higher. That is number one. After between actually 1 to 1 hour, we will get the data. So why 1 hour post-meal glucose or a post-challenge glucose is to be taken into consideration? Are we going to have a paradigm shift in diabetes management? Now, before going into the details, let us look into that what happens in a preprandial state. Preprandial state where the insulin levels will be lower and the insulin will facilitate glucose uptake from the muscle, and then it also, there is a glucagon dominance in a preprandial state so that more endogenous glucose production is there. At a postprandial state, what happens is that more insulin is released, glucagon is cut off, and this in turn, because there is a contribution from the food that you take to the circulation, the glucose, the glucagon comes down, the EPG, that is the endogenous glucose production comes down, and the higher insulin dose further reduces the lipolysis and proteolysis as substrate to the liver, to EPG. And then what happens is that it facilitates more and more glucose uptake by the skeleton. This is what happens. Now, if you look into these two people, that healthy people and as well as type 2 diabetic people, you could see the difference here. In fact, there's one question asked during the last lecture also, how a basal insulin can address the postprandial blood glucose. Now, here if you can see that contribution from the endogenous glucose production, even in a postprandial state, leave alone in the preprandial state, even in the postprandial state, if you look into that, the glycogenolysis and gluconeogenesis, which contributes to the endogenous glucose production, is double to healthy people in type 2 diabetes. And this is what is the most important thing. So, but almost 40% contribution in the postprandial state by the endogenous glucose production. Now, then why hyperglycemia at 1 hour should be considered more dangerous? That is because 1 hour, the level of glycemia reached is generally higher than at 2 hour, especially in the context of Indian population. And as I said, the Dr. Mohan study also said that around 70 minutes or so, the highest postprandial spike has been there. In type 2 diabetes, the post-breakfast peak value is observed between first and second hour. And then after start of the meal, irrespective of the degree of diabetes control HbA1c, while the 2 hour breakfast glucose value is already within the decreasing slope. That goes up, stays for some time, at 2 hours it starts going to go down. Now, this can be really the so-called endogenous glucose production by this study. What they have done is that they have taken regular insulin and Lispro insulin, that is the short-acting insulin analog, which exactly goes at 1 hour, the peak. They're different. The pharmacokinetics are different. So the Lispro, which is a very fast-acting insulin, a fast-acting analog insulin, which goes to the peak in 1 hour and then goes away after 2 to 3 hours, right? Now, if you look into that, the one which is on the left side, if you can see that, the plasma insulin after giving, compared to human insulin, Lispro, you can see that it goes to the peak at 1 hour, and then you can see the blood sugars comes down. What is more important thing is this particular, the down one, you can see that. How is this postprandial is able to be brought down by the short-acting analog at 1 hour, the extra insulin at 1 hour? That is because it reduces the endogenous glucose production better, apart from glucose uptake. And this is what happens here, and then that is the reason 1 hour glucose is 1 hour insulin level is a very, very important thing. Now, if you look into that, this study that has been done, and if you look into what happens to a type 2 diabetic, this is the first phase insulin release, which comes around 1 hour, is absent in type 2 diabetes. And that is the reason this 1 hour value is of great importance. So it looks like that early insulin secretion plays a role in prandial glucose regulation, and abolition of this release results in postprandial hyperglycemia. Early insulin secretion is absent in type 1 diabetes and blunted early in the development of type 2 diabetes. In the absence of early insulin secretion, the stimulatory effect of glucagon in EPG is enhanced, thereby contributing the postprandial blood glucose. This is what has happened. Now, they went on to look into studies such as the so-called Pearson's correlation coefficients between plasma glucose concentration at 60 minutes and as well as 120 minutes during a OGTT versus indexes of insulin secretion and insulin resistance. So with that, the coefficient assessments, what has been found is that apart from stronger correlation with the 1 hour plasma glucose value, insulin secretion and insulin resistance, and insulin secretion resistance index is also different from 1 hour and 2 hour. So 1 hour plasma glucose concentration during OGTT is an independent predictor for developing type 2 diabetes stronger compared to 2 hour value, suggesting a cutoff of 8.6 millimoles or 155 at 1 hour. 155 at 1 hour. Now this is what is also in Indian studies also done. Dr. Mohan has done its study, which is published in 2013. They have concluded in this particular study, among normal glucose tolerance subjects with elevated 1 hour postprandial glucose within the normal limits, during a OGTT, progression to diabetes and prediabetes is greater and the rate of progression is also faster. Again, indicating the 1 hour value is of a very good importance here. Now, all of us know that. We know that the postprandial blood glucose is an independent risk factor of cardiovascular disease. Whether 1 hour postprandial glycemia is an indicator is the one that we have to see. And we can see that the 1 hour blood glucose is also associated with lipid alterations, increased blood pressure, and inflammatory markers as well. So we can see that, for example, we can see that the carotid intima media thickness, which is an indicator for CVD, 1 hour post-challenge glycemia has found to correlate with increased arterial stiffness and CMT in several studies compared to what happens with 2 hour value. That is number one. And then we can see that even the 1 hour postprandial blood glucose is also correlated to increased left ventricular mass and left ventricular diastolic dysfunction compared to 2 hour value. That is number one. Number two is that even within the normal NGT itself, those people who got a higher 1 hour value had a more diastolic dysfunction. So this is another thing, that even in the normal IGT, higher the value within 155. Now, this can be confirmed with Israel study, the study which is done in Israel, which the duration is 33 years, follow-up is for 33 years, sample size of 2,000 plus. And what they have done is they have taken into 4 strata. That is, if you look into that 1 hour less than 155 in a GTT, and 2 hour values less than 140. 140 is the cutoff point for IGT. And group B, 155 and more at the 1 hour value, but less than 140 in the 2 hour value. And group C is that the less than 155 in 1 hour and 2 hour value is more than, that is between 140 and 199. Group D is the one which we have looked into that. The most severe is that people who had 1 hour value of more than 155 and 2 hour value between 140 and 200. So when they followed it up, what has happened was that those people who had a 1 hour value, the worst prognosis occurred in a group D, where compared to followed by group C and respectively, when 2 hour glucose value is normal, the 1 hour glucose value of 155 is an important predictor for increased mortality. That is about 28%. So it is found that 1 hour threshold value is a very great indicator looking into that. So the IDF has come with a position statement in just March 2024, and use a 1 hour plasma glucose test to diagnose intermittent, this is about the complications, even for the diagnosis of intermittent hyperglycemia and type 2 diabetes, depending on the data that they have come. And what they have said, that the statement recommends the use of 1 hour plasma glucose, cutoff point of 155, and 1 hour value for the intermittent hyperglycemia, And diagnostic as diabetes as 209. So this is the IDF statement that has been given. Because why? Because as the evidence shows that this part of this like 1 hour value is associated with more predictability to type 2 diabetes compared to type 2 hour value. Micro and macrovascular complications of obstructive sleep apnea, cystic fibrosis, metabolic dysfunction, like any, that NASH, premature death, everything is correlated with 1 hour value, and that is the reason. So the pathway recommended is that the IDF says that take the high risk population, do a GTT, and take 1 hour value as an indicator, and if it is more than 155, and then that indicates that we need to take a challenging decision to take care of them. Now, when you look into the therapies that are available, which you can see that to address the 1 hour blood glucose value, one is that Dr. Venkatraman is also speaking about that the short-acting insulin analogs are a very good choice to look into that. And ripaglinide, acarbose are in general the alpha glucosidase inhibitors, because if you look into the textbooks, if you look, the effectiveness of alpha glucosidase inhibitors is 0.5. But in our country where carbohydrate intake is very high, that can bring down HbA1c even to 1.5 HbA1c, not 0.5 alone. And of course, GLP-1 receptor agonists are also good for looking into postprandial, and DPP-4 inhibitors also, we know that. So I think we need to look into the 1 hour postprandial basically because it increases arterial stiffness, increases LV mass, dysfunction, LV dysfunction, endothelial dysfunction, and also it is associated with higher triglycerides, ApoB levels, and HDL and triglyceride levels as well. So this is something new. Probably we need to think about that, look into 1 hour value at the glucose and also 1 hour value postprandial state, so that we can do. Thank you from my bottom of my pancreas.
Thank you, Dr. Vijay Kumar. Third year student, third year, final year house surgency there. So he used to call this as early glucose intolerance. And in those days, they kept up to 180 because of renal threshold. After that, urine sugar will appear. So then, under Professor Seshia, we did GTTs. Lots of GTTs were done in GH. Then we observed this 1 hour value above 140 is a predictor of future diabetes. And we have seen many patients also. But I am always hesitant. I did not record them. But we have studied in the GTT club. Then I would like to tell you the importance of 1 hour blood sugar value in pregnancy. Now all people agreed. Is it not? You please include that, then your study will be much more appreciated. Excellent presentation. Thank you. That's all.
Sir, excellent presentation, sir. Actually, we were doing one research also on this thing, sir. In Harvard, we have collaborated and we are doing with CGM, sir, in type 1 diabetes, where we have seen, sir, that with 1 hour, still we didn't publish it, sir, there was increased risk of mild cognitive illness. And we have seen, and with this mild cognitive illness, how it is progressing to dementia is what our research, sir. Where we have seen that the 1 hour risk is there. They are having more mild cognitive illness and they are having more risk for dementia, sir. It is just a pilot project we are doing, sir.
Very, very interesting. The cognitive dysfunction in hyperglycemia 155. Usually it is associated with hypoglycemia, frequent hypoglycemia.
That is what is this thing, sir.
Is the thing. But I don't know. I mean, there's something interesting. Once the results are ready, let us know. I think that also opens our eyes whether
Yes,
we need
sir.
to look into that for cognitive dysfunction.
Thank you, sir.
Yes, sir. 1 hour.
Sir, wonderful presentation. Sir, really, as usual, learned a lot from the lecture. But my small doubt is, when you have first 1 hour increase in blood sugar is high, probably this is contributed by decreased suppression of glucagon secretion. If you give a molecule which suppresses glucagon secretion, probably that 1 hour glucose will comes down.
Yeah,
Is it
naturally.
So we
see, the moment the insulin is available, the glucagon is suppressed.
Yes, sir. So
So
when
that's a correlation
yes,
between
that
the two.
correlation is.
That is in response to Professor Dr. Parandaman's query. Glucagon also stimulates insulin secretion. Also stimulates. not only raises the plasma glucose level, directly as well as indirectly it stimulates. Okay.
No, but in hypoglycemia, no, the GIP comes in and then says that glucagon secretion will be there, insulin secretion come down.
Sir, this 1 hour value, as you said correctly, from little earlier days, we worked on pregnancy. Now, therapeutically, if you ask, already some discussion were going on. Unless you use rapid insulin analogs, whose peak will be 1 hour when you time it with the meal, that 1 hour value cannot be brought down. Our routine conventional short-acting insulin, they peak at 2 hours. Then I ask you, if you take oral drugs, not in pregnancy, can we take acarbose or miglitol or voglibose to peak the 1 hour touch when it is mild?
Definitely.
All
yes.
the glycosurias, all the sulfonylureas cannot touch, metformin cannot touch, DPP4 is late. To touch the 1 hour peak, what drug we suggest?
Yeah, that's a very, very important point. The question is that when you have this 1 hour, 1 hour deficiency, 1 hour insulin secretion is not there, which we cannot mimic it. Probably only the GLP-1 receptor analogs can mimic the 1 hour post insulin secretion. Now, when you don't have a drug that cannot mimic the increase in the 1 hour blood glucose value, and the blood glucose is going up, the only thing what you can do in this pathophysiology is reduce the absorption of the glucose from 1 hour to late into 2 and 3 hours. That's what it is. That is the reason the value of the alpha glucose transmitter comes in, because you cannot do much about that unless you give post analog insulin at that time. So these things will help in not increasing the insulin secretion, but not increasing the blood glucose at that level. So that's how it works.
Sir,
And all-
dosage in each meal.
See, the problem, in fact, this is a very practical point that we have been facing, is that now we have even sulfonylurea, say like for example glycoside, which is in a extended form. So when we started using that, we started getting a problem of postprandial blood glucose. So going back to original short-acting glycoside, at least half an hour before that, and that can mimic to a certain extent. So this is a problem that we faced even then. So suddenly the postprandial will go up. So we need to release sulfonylurea to the beta cells as soon as possible.
Sir, non-sulfonylurea molecules like repaglinide and those things, and taking roughage or salads before your meal, would that blunt this 1 hour?
Definitely, yes. Definitely.
this
Yes. In
1
fact, the
hour
combination
postprandial-
FDCs with repaglinide, such as netaglinide and repaglinide, with alpha glucose inhibitors is available now, actually.
And also a
For 1 hour
non-pharma.
postprandial, if you give sulfonylurea or beta cell stimulant, definitely they may land up with hypoglycemia. As he pointed out, alpha glucosidase inhibitors is safe.
No, see, sir, the treatment is individualized. See, sometimes.
this is after 1 hour
sometimes, yeah,
1 hour
what
hyperglycemia.
you said is right.
This
You
is
can
not
go with
gross
extended
hyperglycemia.
release and add an alpha glucose inhibitor. No harm in doing it. Failing which, only thing is we have to shift that. See, sir, diabetes is such a heterogeneous disease. The response of the disease also to different molecules.
No, the discussion is 1 hour. 1 hour is very mild hyperglycemia. 90% will get controlled by diet alone and exercise. On top of it, if you want drug, the preferred drug is alpha glucosidase inhibitors when compared to even sulfonylurea. Because GLP-1 analog also parenteral. They will not agree.
And also, non-pharmacological treatment, you must be knowing.
More important.
That is the splitting of that to the breakfast and splitting of that to the lunch.
I think Dr. Sundaram
Certainly, it has
always
gotten
says
a
that.
significant reduction in that one role. That is practically, we have seen. Okay, I think.
Especially in the pregnancy, sir. I think pregnancy, because they are motivated. In a regular patient, it's not possible for them. The working person cannot do that. But in a motivated pregnant woman, they will be too happy to have 2 meals so that the postprandial blood glucose.
I think Dr. Shanmugavel is in a hurry, so let us all conclude these sessions. So once again, thank the speakers, Vijay and Vijay and Venki, all these 3 speakers. And I call all the speakers come to the dais to receive that memo. Thank you very much.
Thank you, sir.